I generally divide these notions of artifacts and pitfalls. I use those terms in different ways. I think a pitfall is something that's inherent in the technique that is helpful to be aware of. And the idea that the way we use the word pitfall is something that, um, well, I used to have a boss that when I worked in this fire equipment company, and he used to say, when you see a hole and you fall in, that's not bad luck. That's just dumb. So we want to avoid falling into the holes if we know where they are. And on CT imaging, there are some specific pitfalls that I think you're probably aware of, but we'll just go through a little bit. And personally, I think CT scans are more difficult to interpret than MR scans. On MR scans, usually the findings are pretty evident, and the interpretation is often the problem. On CT, I think the problem for many readers is not so much the interpretation, which can also be a problem, but detection. So the actual detection of the abnormality is the challenge. And the reasons for that are there is lower lesion to background contrast. And if we use the example of stroke imaging, if you're trying to find some changes in the gray-white interface or the margination of the basal ganglia, these are very difficult judgment calls. And the reason why I think you need to know the clinical history, because there are false positives that occur. The other problem is that the conspicuity of normal structures is actually lower. So one benefit you have on MR imaging is not just the detection of abnormalities, but you can rely on the visualization of normal structures to reassure you that everything is normal. So for example, if I see the arrangement of the corpus callosum is perfectly normal, and I see all the normal midline structures, that reassures me that I don't have, say, a mass lesion there. And so I don't have to depend so much on the signal abnormality, but I can look at structural changes. On CT, that's not true. We don't have as precise depiction of the normal structures. And the other issue, which is what I want to talk about, is this fact that you can only see a portion of the data set at one time. And this comes into window and level. So again, MRs we talked about in the last session, there are multiple sources of contrast on MR, T1 weighting, T2 weighting, diffusion, flow, and so on. On CT imaging, we have a single source of contrast, and that single source of contrast is, of course, the X-ray attenuation. The way we read MR imaging is we look at multiple scan techniques. So if I have a question, if I see something, I'm not sure it's abnormal on the T1 weighted imaging, then I'm going to go to the flare imaging or the diffusion imaging. Whereas on CT imaging, we have a single technique, but we can display it in multiple ways. So I can change the slice thickness, I can change the filtering, and I can change window and level. So window and level we use because we can only really perceive about 9 to 10 shades of gray, but we have a range of thousands of Hounsfield units to display. So again, we use the term level, refers to the center of the window, and the window is the range of Hounsfield units that we're going to visualize. So everything above and below the window will appear either as white or black. So if we say the window is 200, then each grayscale, let's say there's 10 grayscale values we can display. Each single grayscale value merges together attenuations of 1 to 20, 20 to 40, 40, 60, and so on. Window of 40 Hounsfield units, I only have to display a range of 4 Hounsfield units. So a narrow window increases soft tissue contrast. So for example, this is the window that we generally recommend for stroke detection or infarct detection. And so this is 40-40. Honestly, I don't always use 40-40. I often use, like, say, 50-50 or something in that range. But the idea is you use a narrow window with the level set about the attenuation of the gray matter. And so on this technique, you can see that there is very nice depiction of the border of the lentiform nucleus here, the head of the caudate, the internal capsule, the thalamus, this little density here, which you might mistake for, say, a colloid cyst, of course, is a calcification in the choroid plexus, which goes, as you're aware, the choroid plexus is not in the frontal horns. It goes through the foramen of Monro, And I'm not sure what your education or understanding of that is, but my understanding is that we were generally taught that the choroid plexus goes from the lateral ventricle into the third ventricle, but in fact, further investigations have shown that the choroid plexus lives in the velum interpositum, which is the space where the internal cerebral veins are. But anyway, this nice depiction of gray-white interface basal ganglion is facilitated by using a narrow window at the level of the brain itself. Now let's look at this case. Here's a young patient was in a contact playing football. Obviously, could be American football, could be European football, but in any event, head trauma is fairly common. So the patient has a head CT scan. Now let's look at it. We look at this in an 80 window level 50. This is kind of a standard CT depiction of anatomy, right? That's kind of a standard window level for head CT. But if we look at the same slice now in a different window, now we have a window of 200. So we have a much larger range. And you can see the patient has a subdural hematoma. Now let's go back to the first window. That subdural, why don't we see the subdural here? It's because the attenuation of the subdural falls into outside of the window, and so it gets put in the same grayscale value as the bone. So, and then if we look at the anatomy, the depiction, here we see the insular cortex, here's the head of the caudate, here's the thalamus. When we look at it on this window and level, you see the soft tissue depiction is much worse. So again, each pattern of display, or each choice we make in display will change, in a sense, what your detection ability is. So when we're looking for intrinsic changes in the brain itself, we're going to use a narrow window. And when we're looking for more sort of a broader range of pathology, we should look in a larger window. Here's another example, just to show you how you learn things, about the case by looking at it in different ways. So this patient has an acrylic cranioplasty. They had a craniectomy at some point. Oftentimes, as you know, these are done for patients with malignant infarcts. And so when if the flap thins or the flap's infected, anything of that sort, they often will use a cranioplasty. These can be metal. This one happens to be an acrylic one, but you see on the standard brain window, it looks a lot like bone. Whereas we look at the same cranioplasty on a bone window, we see that it's obviously quite different from the bone. So again, this is the interplay of window and level that I'm sure you're aware of, and but I just want to encourage you to incorporate that into your practice. And personally, I think you should be looking at the brain in 3 windows. One would be a bone window that's bone filtered. And then you should look at it in a soft tissue standard window, which is like 80, as I say, 80, 50, 150, sort of depends on your site and what you're used to. But then look at also, particularly in your cases where you suspected an infarct, you want to look at it in a narrow window and level. Here's just another example. If you look at this CT scan of the head, let's say there's a postoperative patient, this might be read as an air collection. I mean, it does look just like air, right? But if you look at the same finding here, I'm going to show you in a sagittal view in a bone window and level, we see it doesn't look like air at all. So here's the air in the paranasal sinus, here's the air around the head. This looks different, right? So this is obviously not air. This is a lipoma. This is a large quadrigeminal lipoma in this patient who has probably has some Chiari malformation, something of that sort. You can see from the abnormal corpus callosum and so on. So this looks like fat. When we look at it on MR, it looks like fat. Actually, if you think about it here, you just don't expect to see it here. And it looks just like air here. And again, that has to do with the vagaries of window and level on CT. This is a common pitfall in postoperative cases, at least in my practice, where you see this is air in the ventricle after brain surgery for resection of a tumor. This is an air collection. Notice that these are, the term we use here is anti-dependent or whatever. This is the air floats to the top with the patient on the table with their, the back of their head on the table. But if you look at this area here, which you might say is air, you have to ask yourself, why is the air arranged in this way in the center of the resection cavity? And that's, of course, because it's not air at all. this is hemostatic material. So this is air, but when you look at it in this window, much wider window, you can see that this is hemostatic material with interposed pockets of air and fluid, right? So this is how you learn more information as we look at the scan in different windows and levels. The other topic I want to talk about briefly is motion. CT images, of course, are taken incrementally. They're not a snapshot like a photo or a plain film. And the scan exam may require 10 seconds or more to do the entire scan. And this is something that we always have to keep in mind as we look at CTAs, and particularly, and also becomes relevant when you look at reconstructions of the cervical spine. And this combination leads to artifactual malalignments or pseudofractures. So here's a patient that looks like there's malalignment of the skull here. And this is just, again, this is a motion artifact. You can see some of the blurring that occurs here. So how did this happen? So the part of the scan data, this is probably done in a helical fashion. So on the reconstruction, there was motion at some point and non-motion at another point. This looks like this is whatever, some chronic osteomyelitis or some expanded bone from Paget's disease. This is just a motion artifact in the skull. Here we have the patient has a repeat scan, and you can see that the skull is perfectly normal. So again, be careful about motion artifacts, and I think that this is something that you should keep in mind as you read CT scans. So I'm going to move, as I say, I'm not going to dwell on some of the physics today. I'm just going to kind of go quickly through some of this material, and we'll get to the cases. And I'm going to try to do this in a poll form. So what I'll ask each of you is you'll have a polling button, I think should appear on your Zoom, and you can vote for which choice you think is optimal. So we'll come to that in the next section. So I'm going to talk a little bit about FLAIR imaging, because this is an important part of the range of imaging that we use for brain imaging. And this, of course, means fluid attenuated inversion recovery. And we use an inversion pulse, which allows suppression of the fluid, specifically CSF. And for any of you that have done any kind of imaging research with MR, you know that tap water, for example, does not behave like CSF because of the minerals that are dissolved in the water and so on. So actually, it has a different recovery time than CSF. So FLAIR imaging is very specific for CSF. And anything that alters the CSF will change the way it looks on FLAIR imaging. So blood, pus, contrast, and so on will change the way the fluid looks. So you can think about FLAIR imaging basically as a T2 weighted scan with black CSF, but it's very sensitive to abnormalities of the CSF in the subarachnoid space. And I also want you to keep in mind that FLAIR is not T1 weighted or T2 weighted, it's both. So it's T1 weighted in the fluid and it's T2 weighted in the brain. So things that are bright in the parenchyma of the brain is because of changes in T2 relaxation, where changes in the CSF are due to changes in its T1 relaxation. So let's look at this patient. This patient had a CT scan and the MR on the same day, has a history of worst headache of life 3 weeks prior. So this has a history that's suitable for subarachnoid hemorrhage, but now we're at a point in time where you may not see subarachnoid blood on CSF. So your diagnosis here, well, my diagnosis here would be normal, but here's the MR scan of the same patient. And you can see here's the suppression of CSF in the cortical sulci. And here we have no suppression of CSF in the sulci on this side and in the interhemispheric fissure. So this is due to a change in the relaxation time of the CSF from the added protein and hemoglobin in the blood. So it changes its relaxation time. So we get incompletion suppression of CSF. So this is the sort of the one of the powerful applications of FLAIR imaging, is not just in looking for MS lesions, but looking for changes in the CSF. And this patient had a aneurysm. And again, we talked about this has about the same attenuation as the parent vessel. excuse me, and this would be consistent with an aneurysm rather than a loop that you see here and you see here. So this patient had a ruptured PCOM aneurysm. Here's a CT scan of a patient had a CT was negative, but the LP was positive. Says magicians will say here, nothing up my sleeve. Here's the CT scan. But on the basis of history, an LP was done, and that was positive. Here's the MR scan flare study. Now, what I want you to notice, this finding, the abnormality here is a little more subtle than it is on the previous case. So you can see a little bit of unsuppressed CSF here along the cerebellar fissure. This is a place where you should look carefully, is in the vermis. In the CSF space around the vermis, for example, here, this should all be suppressed like the CSF in the cisterns. But this is due to blood products in the posterior fossa. Here's a little non-suppressed CSF in the occipital lobe. For those of you that are not sort of regular MR readers, you may say, oh, that's really subtle. And yes, it's subtle. But again, remember that when you look at imaging, you're not looking at it like, as an unknown. You will have appropriate history that should lead you to say to yourself, is there any evidence of subarachnoid hemorrhage? So this is a representation of CSF. The patient went on, and I'll show you here's again, this is unsuppressed CSF you see here. And here's the angiogram. This is an injection. Who's gonna tell me? Armin, you wanna tell me what the injection, here's what blood vessel was injected?
I'm sorry, I can't hear you.
Which blood vessel is being injected here on this digital subtraction angio?
It's hard for me.
Artery?
I'm sorry, say again?
She
I
said
don't know.
internal carotid
artery.
or carotid. No, carotid.
Okay, so I'm just showing this to you because I think that it can be challenging at times to look at an image and know what blood vessel it is. So what I want to show you is some landmarks that you should be relying on. Remember that the normal carotid artery has a cavernous loop. So if this is the carotid, you would expect in this location to see a cavernous loop take off of an ophthalmic artery, right, and a posterior communicating artery. Now, these are actually the posterior these are the posterior cerebral arteries here. And then we see this vessel that occurs here, which you wouldn't expect to see on a carotid injection, because this would be, let's say this, here we see the skull base, that what vessel would this be if this were a carotid injection? So now, as I show you these this anatomic depiction, what vessel would you say now that this is?
Which
The
one?
PICOM, the posterior inferior cerebellar artery.
Exactly. Right. So this is the vertebral injection. This is the posterior inferior cerebellar artery. And here you see, this is kind of an unusual case. There are actually multiple aneurysms here. And the reason there are multiple aneurysms is the patient has an arteriovenous malformation. So here you see, so this is kind of all, kind of ticks and fleas, and we see different pathology. Excuse me. Here, these are aneurysms on the supplying arteries to this arteriovenous malformation. And here you see the early appearance of a draining vein, which allows the establishment of that diagnosis. So as I say, as we go along, I'll be showing you more digital subtraction angio cases. I realize this is a problem or a limitation, not just in Armenia, but here, as the world of angiography has moved into the interventional space, but I think we still need to be able to interpret the imaging.
Alex, could you go back to the CAT scan of the patient where you felt was probably normal?
Well, we're pretty sure it's not normal, but whether it would be read as normal is another question.
Right. I mean, in retrospect, everything looks a little bit different. If you go to the level of the tentorium,
Yes, yes, right there.
right there, right
Yes.
there. Now that you're looking at it, how would you characterize this tentorium?
Well, you know, if I were in my own practice, if I saw something like that, I would go to the coronal imaging, because I find that the tentorium, as you know, can be very difficult because some people have calcium along the tentorium. Any head tilt, this one doesn't look very tilted, but any head tilt will change the way the tentorium looks, because remember, if it's tilted, you're looking cross-sectional in one side and sort of obliquely across it in the other. So I find coronal imaging is the most helpful. But in the sense, if I were looking at this from a sort of, someone asked me, you know, would this be malpractice to have read this as normal? Not really. I think for most people, if you didn't have the history and a high degree of suspicion, you might actually go right by that. And the other thing that makes this case difficult is that in most cases of suspected subarachnoid hemorrhage, you'll see blood in this little V at the interpenuncular cistern. So this is I think is one of the sort of the earliest sign of subarachnoid, or the most sensitive sign for subarachnoid hemorrhage, when it lies above the tentorium. But this patient's bleed was posterior fossa. But you're absolutely right, Viken. This is you know, this is a difficult call, but probably abnormal along the tentorium there. And again, comes back to my point why I think CT is so difficult to read, because of these subtleties of detection. And MR is more, things are more conspicuous.
Sorry, can I give a question? If you see subarachnoid hemorrhage on FLAIR images, is it will be reliable to go on diffusion images, or it's no need just to see on FLAIR and no need to correlate to another sequences?
Well, okay, that's a good question. So let me just start with at the beginning. If you see an abnormality on the FLAIR scan, sorry, let's go back to that. If you see an abnormality on the FLAIR scan, just as as I tried to say, if you see an abnormality on the diffusion scan, not all abnormalities on diffusion are infarcts, and not all abnormalities on FLAIR are subarachnoid blood. I'm sure you know. So I just want to emphasize that if you can see the same pattern in patients with carcinomatous meningitis, you can see the same pattern in people with meningitis. So all you can say is that there is an abnormality of the subarachnoid space. And if you're not sure, then I think those cases should go to spinal tap. And I'm going to show you there's some other pitfalls on FLAIR imaging. Having said that, I think your question is, will subarachnoid blood alter the appearance of diffusion imaging and susceptibility weighting imaging, or shallow flip angle gradient imaging? And my answer to that is no. I find that it's unreliable. I've seen a lot of cases where I'm tempted to say it's not blood based on the lack of susceptibility effect on SWI imaging, but in fact it is. So I think this is I think that's the algorithm I use, is I see an abnormality in the subarachnoid space. If I don't have a strong feeling from the history, I go to spinal tap. But do the other scans help you discriminate blood from pus? My experience is no, it does not.
Thank you.
No, it's
Alex,
a very good
question too.
Yes.
How sensitive or accurate, perhaps a better word, is a CT for subarachnoid blood in an aneurysmal patient? Say you do the CT within 24 hours from the onset of symptoms. And this is a question that in the emergency room I face all the time. Patient has sudden severe headache, the exam is normal, you're very afraid there may be an aneurysm, the CT is normal. So what's the chance of missing subarachnoid hemorrhage if the CAT scan is done within the 24 hours?
Okay, so there's two parts to that analysis. And this is the same sort of thing we confront when we ask the question, how accurate is CTA for detection of aneurysms? The first part of the question is, who's reading the scan? So as you saw with that other CT scan, sometimes the detection of subarachnoid hemorrhage is very difficult. So I would say that is, can we be confident that with the best possible reader, we'll pick up 100% of subarachnoid hemorrhages in the first 24 hours in patients with a ruptured aneurysm? And the answer is no. And I think there was a recent study that talked about that, was comparing CT imaging with lumbar puncture and other studies. So what's the number? I think it depends on the reader, but I think it's small. It's probably in the 5% range, maybe under 5%, but it's not zero. And I think the challenge for the individual seeing the patient in the emergency room then is, do we do a spinal tap in everyone with middle-aged patient, worst headache of life, with a negative CT scan? Do we do an MR scan in those patients? There isn't one algorithm where they do a CTA in those patients rather than the lumbar puncture. So I guess I can't really advise about the clinical part of it, but from an imaging point of view, a negative CT scan does not exclude the possibility of a ruptured aneurysm.
Thank you. That's very helpful to me. How about if you take the algorithm that you indicated, the CT angiogram, then add it to the CT? How much more accurate did we get at that point?
I think then now we're in the small numbers. There is a possibility then that you will have, they say true and unrelated. So in that scenario, you can have a patient with a severe headache, a negative CT scan, and an aneurysm on the CTA. So you can't then assume that the patient has a ruptured aneurysm because we know that about 3% of the population have aneurysms. So you could actually pick up an unruptured aneurysm coincidentally in a patient with severe headache. So my sense is at that point, you still need to do a spinal tap to see if there's evidence of blood. But if I had a patient in that scenario with a negative CTA and a negative CT scan, I think that the chances of that patient having a ruptured aneurysm is extremely small, maybe in the less than 1%.
Thank you. So should a radiologist, if I go to the radiologist's office, if I come to your office, say, I have this patient in ED, severe headache, very clinically suggestive of subarachnoid hemorrhage, and the CAT scan is negative, would you push me to say, go ahead with a CT angiogram, or should I go to an MRI or MRA? What should be the fork at that point?
Okay, I don't know if this is a good example. The problem with FLAIR, one of the hospitals I worked at, they use that algorithm. Negative CT, suggestive history, they were doing FLAIR scans. Here's the problem with using FLAIR scan. In many patients, and depending on how you do your FLAIR imaging and your scanner quality, there will be unsuppressed CSF in the pre-pontine cistern. This is not blood here. This is actually, in most patients, this is an artifact. So because even in normal patients, all the CSF is not suppressed on FLAIR scan. At the end of the day, you're going to say on every FLAIR scan, I'm not sure. So I don't recommend MR imaging in that scenario. If you say to me, you have a patient in the emergency room who has, very suggestive history, negative CT scan, and they're on anticoagulation, and there's a risk of doing a lumbar puncture, or there's no one available to do a lumbar puncture in the middle of the night, then I think it's reasonable to do a CTA. But I guess I think there are problems of, I don't know that CTA is in a patient who really has, let's say they're 49-year-old hypertensive who smokes, who may have a family history of aneurysms, comes in with a history, you think there's a subarachnoid blood, then they should probably just go right to LP. So I don't think there's one algorithm that works for everyone, but I don't think MR is part of the algorithm.
Thank you.
So let's talk about a little bit about some of the other reasons why FLAIR scans are abnormal. So here's a patient, again, just another example. And what it comes back to is, what is a negative CT scan? So would many readers in a busy practice, maybe without appropriate history, miss this? Probably. But this is subarachnoid blood in a very subtle presentation. Now, again, conspicuity is much higher on the FLAIR scan, but strictly speaking, this CT scan is abnormal. But will it be read as abnormal in every case? Probably not. So this is the problem with detection of CSF. It's all sort of in the eye of the beholder. But I think you have to be very conscientious to detect subarachnoid hemorrhage. Now, the best way to detect subarachnoid blood in CT, coming back to the first part of this talk, is to look at thin sections. Because the problem with subarachnoid blood is because of the phenomenon of volume averaging, the blood is oftentimes being averaged with normal CSF in a large voxel. So that makes it less apparent. If you want to maximize the conspicuity of subarachnoid blood on CT imaging, you really need to look at slices thinner than 5 millimeters. So again, I just want to show you how subtle it can be. Here's another example. This is probably the most subtle example I have. I'm going to show you today. This is subarachnoid blood on a CT scan. This is subarachnoid blood on a FLAIR scan. So I think the two of them allow you to make the assessment quite confidently, but this is what you're up against when you ask the question, what is really a CT negative, a negative CT in the setting of suspected aneurysm? This patient actually had vasculitis. Now, this is a pitfall that for those of you in hospital-based practices will confront. Let's see, we'll talk a little bit about this. This looks like abnormal CSF diffusely. You see you have unsuppressed sulci on FLAIR imaging throughout with a focal area of what looks like a lot of abnormal CSF here, right? Now, and remember, these scans are T1 weighted and T2 weighted. So this is the T2 abnormality in the parenchyma. This is the T1 abnormality or alteration of the T1 relaxation in the CSF on the FLAIR imaging. Now, this patient had a tumor, and this is contrast enhancement with gadolinium. So what happens in these patients is the gadolinium actually leaks out from the tumor into the subarachnoid space, in that way altering the relaxation time of the fluid. So in this patient, it would be a mistake to overread this as, say, carcinomatous meningitis in a patient with metastatic disease. This is gadolinium leaking into the subarachnoid space. Now, this can happen in patients without a tumor or a interruption of blood-brain barrier. So this can occur in patients with contrast administration, let's say on Monday, if they have renal impairment, or even if they have normal renal function, it's been reported, gadolinium leaks from the meninges into the subarachnoid space. So previous administration of gadolinium, I would say within a week, depending on the renal function, you can actually see the contrast in the subarachnoid space. Here's a patient, and they show you, this is, you can see this abnormal FLAIR scan, and this is a patient had normal renal function, had MRA, and this was a follow-up on the next day. So again, when you see this pattern of diffuse abnormality of the subarachnoid space, you want to ask the question, did they receive gadolinium contrast in the previous 48 hours? This is a patient, 18-year-old, scanned under anesthesia. So if we look on the FLAIR scan, again, it looks like a diffuse abnormality of the subarachnoid space. And while one would say, okay, this is an abnormal FLAIR scan, the next question is it pathologic? And in a case like this is not pathologic. This is due to anesthesia. Now, I want to use this case to illustrate something for you in terms of your increasing your sensitivity to FLAIR abnormalities, particularly in young patients who have oftentimes normally have narrow sulci because of their generally large brain volume before the atrophy sets in at sort of my age. So here I can see it looks like I have obliteration of the normal signal in the sulci. But I might ask myself, well, maybe there's no fluid space there. Maybe the sulci are effaced because of the volume of the brain. So what this is a reversed T2 weighted scan. So, I'm sure these day and age, I think, at least in this country, I imagine in Armenia, you're all reading off of PACS monitors. So there should be an option on your PACS to reverse the contrast on the image. So and by reversing the T2 weighted scan, you can see where the sulci are. So that allows me to say the reason I don't see any sulcus here is because the CSF is abnormal. Whereas over here, the reason I don't see any CSF is because the sulci are effaced by the volume of the brain. So use that technique when you have a question about whether you're looking at just a large brain volume or you're looking at effacement of the subarachnoid space. And this sort of speaks to the sensitivity of FLAIR imaging, is that just the simple breathing of oxygen, whether that's from a rebreather mask with 100%, or particularly in patients with anesthesia, which, as you know, they will increase the PO2 prior to the induction of anesthesia, particularly in children, the oxygen will alter the relaxation time of the CSF enough that it's visible on the FLAIR. And this, if you want to read about it, there are a number of papers about the paramagnetic effect of supplemental oxygen. If you go back to the literature, I'm not sure what you were taught or what you learned. This was actually attributed to the anesthetic agents, but I can tell you this is not simply due to the anesthetic agent, it's simply due to the oxygen itself. So you don't need for there to be anesthesia as well. And so again, if you look at this MR scan, FLAIR scan, it's abnormal. Look at the chest film of this patient. This patient actually had a trach tube and was being ventilated during the scan. So now the problem in this scenario is, let's say in the patient who's intubated, the question being asked is, could this patient have subarachnoid blood? Could the patient have meningitis, which often comes up? Your answer has to be, I don't know. And I think in medicine, we just have to be prepared to give that answer. And so do I know that the subarachnoid space is normal in this patient and this is all oxygen effect? No, not really. So if you see marked asymmetry, then it's probably not oxygen effect. Usually the oxygen effect is diffuse throughout the brain. But again, I usually just say, I don't know, and you have to tap the patient to find out.
Very sorry, I'm terribly sorry. Can I give one question again?
Yes,
if we need to check for meningitis or for subarachnoid space, in some literature I found that they use T1 FLAIR, not T2. What do you recommend? T2 FLAIR is more sensitive, or T1 FLAIR?
Well, that's an interesting. I don't have a lot of experience with T1 FLAIR for, you're saying for detection of meningitis?
Yes, for meningitis, yeah.
I can't really speak to that because I don't really have that experience. And I have personally, I think, I don't think there's anything. I mean, I'd be surprised if it's more sensitive than the T2 weighted FLAIR. But I'd have to, is that where did you read that, or which journal that was in?
I tried to find article and send it to you.
I really appreciate that. And maybe we can speak about that at the next session.
Thank you very much. Thank you.
But I will caution you, there is one scenario that some hospitals have moved to in patients with cancer looking for carcinomatous meningitis, and they do gadolinium enhanced FLAIR imaging. And I think that is a valid approach, but also fat suppressed T1 weighted imaging is also extremely sensitive for carcinomatous meningitis. So I think that's a pulse sequence that I am very familiar with, and I think that's very effective in showing the abnormal leptomeningeal enhancement. The reason being that fat suppression, it actually has a magnetization transfer effect, and it decreases the signal of the brain and maximizes the conspicuity of the enhancement. So, but again, please send me that article and maybe we can.
Thank you very much. Thank you.
This case, I just want to show you, this is a patient who has this, looks like a fluid space on the, this is a CTA, of course, and it looks like there's a fluid space in the medial temporal lobe. And so obviously this is a common location for a benign choroid fissure cyst. But when we look at it on the FLAIR scan, you can see that we have high signal intensity arising from that same space that differs from the fluid in, let's say, in the interpeduncular cistern and here along the sylvian fissure. So that's what tells you this is not a benign cyst like an arachnoid cyst or choroid fissure cyst. This is a tumor. This turned out to be a DNT. So again, FLAIR imaging is very helpful in distinguishing benign from malignant cysts. Here's a patient who actually does have a choroid fissure cyst, sort of same location. This is what it looks like on the FLAIR scan. Here it is on the T1 weighted imaging. So again, if we think this is a benign cyst, it should suppress on the FLAIR scan. Here's another patient, multiple cysts you see here along the internal capsule. This patient had no neurologic deficits, no symptoms that were sort of suggestive of a tumor. Here you see it on the T1 weighted scan. Here you see on the FLAIR scan, it looks exactly like CSF in the ventricle. Here it is on the post-contrast imaging. And these are giant perivascular spaces. So these, some people call these tumefactive perivascular spaces because they resemble tumors, but keep that in your differential. When you see unsuppressed CSF in cysts, it happens occasionally with low-grade neoplasms, sort of WHO grade 1 tumors will often have areas of cysts that suppress on FLAIR, but those cases will always have abnormal parenchyma. Now, what confuses the case is that some patients with giant perivascular spaces can have little areas of T2 prolongation, but they won't have large solid areas of T2 prolongation. So again, be aware of this tumefactive cysts. This is a very important pitfall that I've confronted in my own career a couple of times. This looks like a perivascular space in the sense that it suppresses completely on the FLAIR scan, resembles CSF here, but there's a lot of abnormal signal around it. You see that here? So this one is very tempting to call a neoplasm. And for reasons that are completely unknown to me, this has been reported, and this is called a subcortical cyst in the anterior superior temporal gyrus. For some reason in that particular location, these look exactly like tumors. And I think that if you can recognize this variation of the appearance of a perivascular space, you can save the patient a biopsy or open surgery. So be aware of that variation on FLAIR imaging. This is one of the few examples where a giant perivascular space can have a lot of abnormal signal. And then the other thing you need to be aware of is what's the limitations of FLAIR imaging. So here's a patient with a metastatic lesion. You can see the abnormality on the FLAIR scan is actually, in this case, fairly subtle, or in this case, it's completely inapparent. So a normal FLAIR scan, as sensitive as it is not sufficient to exclude metastatic disease. In fact, there's nothing really more sensitive than the enhanced study, and you don't really need the FLAIR scan if the question is metastatic disease. But just be aware FLAIR is not always sensitive for abnormalities, particularly in the cortex and where there's very little vasogenic edema. The other area, here's a patient with, I'm sorry, these are diffuse Mets. Here's one here, here's one here, here's one here, here. This is, some people call these miliary metastatic disease, and you can see the FLAIR scan is essentially normal. This one, which looks like it could be a lesion, actually is not enhancing. This is probably a little bit of age-related change. So again, FLAIR is not sensitive for all abnormalities of the brain, and this is particularly true for multiple sclerosis. Here you can see an MS lesion here on the T2 weighted scan, barely visible on the FLAIR scan. So FLAIR is not a standalone, detect whatever's wrong with the brain study. And this has been, sort of discussed in the literature. It's you can't use FLAIR alone to look for MS lesion. Here's this is an important artifact that you'll confront now and then. This looks like an abnormal FLAIR scan on this slice, but when you look at this slice, you notice that the CSF in the ventricle is not suppressed. So the one thing that people don't consider all the time is the ventricles and the subarachnoid space in theory are different spaces in the sense that the fluid in the overlying the ventricles actually went through the ventricles down along the spinal cord and comes up along the convexities to be resorbed in the arachnoid granulations. So if you think about it, the ventricles are in a sense like water, are upstream and these are downstream. So if the FLAIR scan is done correctly, the fluid in the ventricles is nearly always normal and dark. So even patients with diffuse abnormalities in the subarachnoid space, the ventricles will look normal. When the ventricles look abnormal, you have to go back and ask the technologist, how was the scan done? Because an error in acquisition can give you this artifactual appearance. So this scan, we recognize that this was odd. We rescan the patient at the correct imaging parameters, and now you see the ventricles are suppressed. So again, use that as a baseline reference point for your FLAIR scan. If it's done correctly, the ventricles should be dark. Here's a patient where it looks like there's a mass lesion here impinging on the medulla and on the inferior cerebellar peduncle. And here it is on the T2 weighted scan. Here it is on the FLAIR scan. And you say, well, look, there's an abnormality there on the FLAIR scan. There must be something in there that's not CSF. But this is just pulsation artifacts. So again, I mentioned that CSF is often unsuppressed in the posterior fossa. Some people think it's due to magnetic inhomogeneity induced by the petrous bones, but this is unsuppressed CSF pulsation. Here's the diffusion scan in that patient, completely normal. So this is a more sensitive technique looking for an epidermoid. This is an arachnoid cyst. Here's another case. Looks like there's a mass lesion here, distorting the cerebellum a little bit on the medulla here. Here's the FLAIR scan, and this is an arachnoid cyst. Now let's look at this one. Same sort of look. Here's a mass lesion on the middle cerebellar peduncle, sort of stretching. This is probably the 7th nerve here. And here it looks like there's a mass here. Could this be an arachnoid cyst? Here's the FLAIR scan. It looks abnormal on the FLAIR. And you say, well, you can't fool me. I just, I know this could be a pulsation artifact. So this is the diffusion study. So the diffusion will be abnormal in cases of epidermoids, and use that as a more reliable technique than the FLAIR for looking in fluid spaces for epidermoids. Here's another case. This is an epidermoid. Here's the T2. Here's the FLAIR scan. Here's the diffusion study. So diffusion, not FLAIR for fluid. All right, so that's all I want to talk